any delay, I'm going to give the floor to Dr. Sadeer Hannush.
Thank you. Thank you, Nadam. Thank you, Dr. Jabour, for working with me over the past few weeks to make this possible, and for your leadership of the Lebanese Ophthalmological Society. It's truly an honor to be with you today, and I thank you for making this possible, as well as Dr. Karim Tameh, who advised us last week, and Dr. Shadi Awad, who will be moderating today's session and helping with the chat box. So I'll get started. The topic here today is secondary posterior chamber intraocular lens implantation in the absence of capsular support. I have a lot to share with you. I've been interested in this topic since finishing fellowship in 1988. And obviously the field has evolved tremendously. And what I would like to say at the outset is that much of the surgical techniques that I'll show today, you have access to, either through your faculty or your colleagues or on YouTube or other media. So you have access to all the techniques. The question is how to approach these patients in your practices, whether academic or private. And the one thing I've learned over the past 30 some years is if you're going to do this type of work, you need a certain degree of commitment to this part of your practice. This is not something you want to do every 1 or 2 months. And the reason I say that is because based on the epidemiology of disease, if you will, of this type of problem, any one ophthalmologist is not going to see enough of this to be able to do it regularly. And we've come up with a number on our service of what regularly means. 2 cases a month is a reasonable number for anyone to do. But if you're doing 2 cases a year, you may want to send it to someone a little bit more experienced in doing this type of work. And I hope that's the way things are done in Lebanon, as they are here. For example, in the Delaware Valley, which is the Philadelphia metropolitan area, there are about 300 ophthalmologists who are practicing in this area for a catchment area of about 7 or 8 million people. And of those 300, you have some of the retina people who are doing this type of work. And then there are only 5 of us anterior segment surgeons who are doing this type of work. So we get to do it pretty frequently. Just a little background. I have no financial interest in the subject matter of this presentation. I am a consultant for COA. This will not come up in today's conversation. COA, as you know, makes a product called Glanatec, which is a Rho kinase inhibitor, Reposidil, which we are using with Descemet stripping only, without endothelial keratoplasty. So these 3 pictures show you the type of presentation you may see. Slide left is a patient with an open posterior capsule, residual cortex. You can see the superior haptic of the implant. The implant has sunsetted. The middle slide is a sunsetted implant with no evidence of residual capsule, although some of it is there. You can see just a little bit here. And the question is, does this need to be repaired or not? And obviously, slide right, a subluxated implant with significant amount of cortical material. So here's the guideline to today's talk. There are several options for the management of dislocated implants. Observation, obviously, repositioning and fixation, removal and replacement with an anterior chamber implant. And I'll say a little bit more about that. And in my case, preferably a posterior chamber implant, either fixated to the iris or preferably to the sclera with sutures or without sutures, using one of the techniques you're all familiar with. So here's a gentleman that was referred to me, 75 years old. The lens is subluxated inferiorly. He has a beautiful anterior rhexis, an open posterior capsule because he had a capsulotomy. Notice the lens is in the ciliary sulcus and it's subluxated inferiorly. So the presumption here is that there is some kind of zonulopathy inferiorly and the lens has gone, or at least the haptic of the lens, the inferior haptic, has gone through an opening and the zonular support. Now, when I asked this patient why he was referred, he says, I don't know. They told me you're the best. That's the kiss of death when the patient comes and says you're the best. Are you having any complaint, Mr. Jones? No, I see just fine. Well, you may look at this and see, why does he see just fine? Well, he sees just fine because the visual axis is still through the edge of the optic. So from the patient's point of view, there's no problem here. This is bothering the referring ophthalmologist more than it's bothering the patient. Now, most ophthalmologists do not have an endothelial cell counter in their practice. But if you do an endothelial cell count and you see the picture on the right, this patient has less than 400 cells per square millimeter with significant pleomorphism and polymeganthism. So if you were to do something with this implant, the cornea is almost surely to decompensate, and you will be in a position where you say to the patient, I fixed your problem, and he says to you, well, how come I can't see anymore because of the corneal edema requiring another procedure? So I think when you look at these patients, you have to decide, should you do anything at this juncture, or just simply leave them alone until either the lens subluxates further or the cornea decompensates? If you plan to approach it at this point, a careful discussion is required with the patient as well as with the referring ophthalmologist if you want him or her to continue to refer to you. And then you have to decide, do you do a simultaneous endothelial graft or not? Here's another common scenario. A patient with an anterior chamber implant did well for a while, referred to you by the referring ophthalmologist because of picture in slide left. You do an OCT and you see the picture in slide right. The vision is about 20/80, 2100, and he's referred to you presumably for a poorly positioned anterior chamber implant. But the reason for the visual compromise is the significant CME. This is a retina with a central retinal thickness of about 800 microns. So you know that this is the problem. Now, to share with you a few things about this scenario, specifically about this scenario, I should let you know that until about 5 years ago, the number one implanters of anterior chamber implants at Wills Eye Hospital were our retina service. So a classical scenario would be of a dropped nucleus into the vitreous cavity or a dropped IOL. The retinal surgeon would go into the eye, do a professional vitrectomy. You'll see why I'm calling it a professional vitrectomy, because the retina people do a professional vitrectomy. Anterior segment surgeons may not, but hold on to that thought. And then he or she will either place an anterior chamber implant if the patient was aphakic, or would reposition the posterior chamber implant, possibly suture it or do something else with it. But nevertheless, anterior chamber implants were very, very commonly placed by our retina service. The argument they would make is that the likelihood of CME in the presence of an anterior chamber implant is very low if a professional vitrectomy were performed. The retina people at Wills were not too concerned about corneal decompensation, glaucoma, or an UGG syndrome. Although in my opinion, massive CME is part of an UGG syndrome, uveitis glaucoma hyphema syndrome. So if this case were then to be referred to a retina specialist, so the patient is looking through the optic of the lens. If it were to be referred to a retina specialist, at least on this side of the Atlantic, this patient would first get peribulbar steroids, plus the topical steroid and non-steroidal. Then they may get an intravitreal injection of steroids, specifically triamcinolone. And then they may get an Ozurdex implant. And these things may temporize the problem for a while until it comes back. And the reason it's coming back is because the implant, even though the patient is looking through the optic, the haptic of the lens is in the ciliary body, creating chronic inflammation. All right, here's another patient with a subluxated implant. You can barely see the haptic. I put this slide up to say to you that if for those of you who want to do this on a regular basis, I truly believe you need to familiarize yourself with a pars plana approach to the vitreous cavity. If you have the luxury of having a retina colleague in the room next door, When you're operating, there's no need for that. You can schedule the case simultaneously with a retina colleague. But if you don't, so in my case, when I'm at the main hospital downtown, there are at least 2 or 3 retina people in the operating room at all times, because we have 7 or 8 operating rooms. But when I'm in one of the outlying surgery centers that Wills has surrounded the city with, we don't have a retina specialist. So you've heard the expression that when there's a necessity, it's an opportunity to learn things. So necessity is the mother of invention. So it's a good idea to familiarize yourself with a pars plana approach to the vitreous cavity. In my case, I use 23 or 25 gauge cutters, but of course there are finer cutters. The problem with the finer cutters is that the wand of the vitrectomy cutter is too flimsy. So yes, you can do a nice basic vitrectomy, but it's hard to use it to manipulate the implant if you're going to use the probe to manipulate the implant, other than putting graspers into the vitreous cavity. We'll get to that in a little bit. Okay, so back to this. Familiarize yourself with a pars plana approach if you are going to do this on a regular basis. Secondly, familiarize yourself with at least one scleral fixation technique, either with suture, and when we talk about suture, obviously we're talking about 9O polypropylene, 10O polypropylene, or 8O Gore-Tex. By the way, for those of you who use 8O Gore-Tex, it's a very neat technique. It has certain problems that you need to familiarize yourself with. I'm happy to talk about that today. The labeling on the 8O Gore-Tex from the company called Gore used to say specifically not for ophthalmic use, which is a medical legal problem in the US, but since 2018, they took it off the labeling. And it's still, all of this is practice of medicine. These sutures were not intended for ophthalmology. Okay? So I started sclerally fixating implants in 1988, immediately out of fellowship. And fast forward a decade and a half, the Academy asked me to write a monograph on this technique. And so this is about 15 years old. I think Dr. Jabour included it in your communication. I think it's still valid today for those of you who like to use suturing techniques. And we'll talk a little bit more about this if you're interested. But the idea here is, I believe that the implant, I always say to the residents, whether you're a creationist or an evolutionist, God or nature intended the lens to be behind the iris plane. Now, not everybody agrees with that, but anyways, so if you believe that the lens belongs behind the iris plane, away from the corneal endothelium, away from the trabecular meshwork, and is less inflammatory than an ACIOL, then this is one technique. Obviously, you have the monograph, so you can look at it, and it kind of nicely shows the different steps of how to do this. And there are many, many videos online that you can watch. Different surgeons have different techniques. But I can tell you that the lens we use the most, at least in the US, is this Alcon product. I'm not a consultant for Alcon. This is the CZ70BD, which, as you know, is a one-piece polymethyl methacrylate lens, total length 12.5 millimeters. The optic is 7 millimeters. And it really lends itself to one of many transscleral suturing techniques. There are different ways to tie the suture either to the haptic or through the eyelid or through a cow hitch. There are different techniques. So over the past 32 years, I've accumulated quite a few of these, and I'm desperately waiting for a resident to volunteer to write this up. No takers thus far. You can see that I don't favor an iris fixation technique, but that is very popular in the anterior segment literature, specifically for those of you who read the Orange Journal, the Journal of Cataract Refractive Surgery. This has been described many times, including the classical article by Walter Stark and Dr. Condon from Pittsburgh many years ago. I obviously favor a scleral fixation. So what I'm going to do with the videos is to try to give you one pearl on each video, not to basically teach the technique, because this is all available to you online. This is just an aphakic patient, and this is basically showing the use of transscleral suturing with tenopolypropylene suture to suture a CZ70BD lens, okay? And the criticism over the years has been, did I lose you?
There's just no screen. There's just red, you're writing, you're using something.
Yeah, I see that. I see that my email, I just have to see what happened here. I must have clicked on something. Bear with me. This is a problem I've never encountered, so I'm going to get out of this. And Neda, I may have to force quit here and join the meeting again because this is very bizarre. I've never, am I back? Neda?
Yes, you are.
All right. All right. So what I was saying here is this is simply showing the technique of using tenopolypropylene on a straight needle to suture a CZ70BD lens to the scleral wall. I probably have done more of these cases than any other type of scleral fixation because I didn't start using the glued IOL technique till 2013 and the Yamani till 2016 and the Canabrava last year. The importance of this, you may be aware that many people in the 90s and 2000s criticized these techniques by arguing that polypropylene suture eventually breaks or lyses. Now, cardiovascular surgeons will tell you that polypropylene doesn't really break unless it's under stress. So what happens with tenopolypropylene is that it chafes on the edge of the haptic or through the eyelet. If the eyelet is not smooth, depending on the lens you use, also it can cheese wire through the sclera. But my argument over the past 30 years is that if that were to happen, Dick Lindstrom used to say it happens on the average at the 15 or 16-year mark, they would have had a decade and a half of CME-free, glaucoma-free, UGG syndrome-free vision. And if the lens dislocates, as you will see in a later video, you can always fixate, as opposed to making that an argument to suture to the iris or to put an anterior chamber implant. So all of you recognize Gore-Tex, and you can do a lot with Gore-Tex. One thing that took the retina field by storm is the use of Gore-Tex to suture Bausch & Lomb's Acryos lens, which is the AO60 lens, and it was published in the retina literature and became very popular. As you know, the Acryos lens is a hydrophilic acrylic lens, and in many of these cases that are complicated and that require gas, many of these lenses will opacify. So I am not a fan of suturing an acrylic hydrophilic lens, but of course a hydrophobic lens does not behave that way. The only thing to say about a Gore-Tex is the suture has to be buried. You cannot leave any part of the suture on the surface because it can erode through the conjunctiva, and that can cause melts and serious complications, which we didn't know 5 years ago. All right. So here's a patient who has a dislocated implant. Now I want to say something. You may say, well, Sadeer, I don't see the implant to be significantly dislocated. Well, then when they were sitting upright in your slit lamp, it was significantly inferiorly subluxated. But they say to you, but when I lie on my back and look at the ceiling, I see fine. And so you know that this lens is subluxated. You can jiggle it in the operating room and confirm that. Now, the reason I say that is for a different scenario that all of you will see. Patient comes into you with a subluxated implant, holding on to the ciliary body with a few zonules, and they're inferiorly subluxated, but still in the retroiridal space. So you say to yourself, I can handle this problem. It is very important to lay them flat in your examination lane and see where the lens is when they lie flat. If the lens disappears from view, then you have to decide, is this you want to handle, or do you want a retina colleague to join you on the case, or do you want a retina colleague to do the whole thing? Okay, very important. You do not want to meet the patient in the operating room and can't see the lens behind the iris plane. I see. So here we go. This is the classical technique that Amar Agrawal described in I would say 2006 or so. It was not adopted until the early 2010s. I'm creating scleral flaps here as you would for a trabeculectomy. Now, there are many advantages to entering the vitreous cavity through the pars plana, and this is not a talk about pars plana vitrectomy. You have many retina people who can do it justice, but I definitely think that will help you significantly. So here I am entering with a 23 gauge cutter and doing, I would say, a limited anterior vitrectomy. And then you can use either the vitrectomy probe or